Hi, this is Mark Purdue, and you're watching a video on interstitial lung disease. So the first thing we should know about interstitial lung disease is that it's currently having its name changed to diffuse parenchymal lung disease. Seems like we should be able to get this straight at some point, but for now, know that interstitial lung disease goes by another name of diffuse parenchymal lung disease. In this video, we are going to describe the epidemiology, definition, pathophys, clinical presentation, diagnosis, and management of selected interstitial lung diseases. We will briefly discuss the range of interstitial lung disease, but we will focus mostly on idiopathic pulmonary fibrosis and sarcoidosis. Recall that the interstitium is a unique physiologic and anatomical component of the lung. If we start with the lung parenchyma, it is the tissue of the lung itself. And if we were to think of the parenchyma as being constituted by airways, alveoli, the vessels, and the interstitium, as the graphic in the left lower hand suggests, is a kind of sponge-like internal scaffolding that creates these inner spaces, hence interstitium, between the functional units, the alveoli of the lung. Now, these units have a distinct potential space to them. As the graphic on the right suggests, the interstitium is constituted by the cell layers of the other components of the lung parenchyma. Recall that lung disease can be roughly divided into two basic forms, obstructive and restrictive. Now, on the restrictive side, we know about mechanical causes such as the chest wall limitations associated with kyphoscoliosis or obesity, but also neuromuscular disease, both acute and chronic. Here we're dealing with restrictive lung disease, which takes the form of an assault on the interstitium, and we know that this can be acute and chronic. In acute forms, we've talked about acute respiratory distress syndrome and then neonatal respiratory distress. Here we're going to focus on the interstitium in its chronic form. So interstitial lung disease, or its new designation, refers to a heterogeneous collection of more than 100 distinct disorders that are kind of grouped together because they share clinical, radiographic, or pathologic features. So a patient comes in with shortness of breath, non-productive cough, maybe some digital clubbing, and so then we have to find out what's going on with the patient. We might start with a history, physical examination, chest x-ray, and pulmonary function test. And what we're going to find in a preliminary way is going to be something along the lines of restrictive pattern in terms of PFTs, and then maybe on the left-hand side you can see this chest x-ray, this kind of diffuse reticular pattern, which tends to be worse in the lower bases. So this might be the presentation of any one of these 100 distinct disorders, but to further refine that, we have to look down the road in terms of their pathologic and histologic characteristics. With that in mind, folks that present with restrictive lung disease, and we consider them to be interstitial in nature because they are chronic, we will then come to a designation of histology. Or to put it differently, in chronic interstitial lung disease, the first designation, or distinction I should say, between the major groups are going to be based on a histologic designation. In the far right-hand side, we have the so-called rare forms, and there are many of them, and the terminology used to describe them, like cryptogenic organizing pneumonia and things of this sort, is very confusing. So stick with me in terms of this basic designation, and we can kind of wade our way through these complex disease processes. Next in the middle, we have granulomatous disease. Here we're going to find two distinct entities. One is sarcoidosis, which we'll spend some time on, and the other one is hypersensitivity pneumonitis, which we covered in our video on occupational lung disease. In hypersensitivity pneumonitis, patients exhibit cough, bronchospasm, and acute illness, which becomes chronic over a period of time as a result of exposure to some kind of organic matter, whether it be bird feathers, dust, mites, molds, things of that sort that they may encounter in the line of work. Hence, that's why we put those in occupational disease. Now, one histologic reaction that the lungs can have to these antigens is a granulomatous reaction, or the formulation of granulomas. However, you should know that hypersensitivity pneumonitis can also terminate in fibrosis, which would scooch it over into the UIP category. Moving over to the left, we have the usual interstitial pneumonia, and this has a distinct histologic appearance, which we will review shortly. If we can identify a cause through history and physical examination, we may refer to that cause as, for example, in a coal mine worker, pneumoconiosis. We might also, if we have a patient with rheumatoid arthritis or scleroderma, refer to the connective tissue disease as the cause for that histologic pattern and subsequent clinical presentation of their lung disease. And then if we find out that they're taking a medication like nitrofurantoin or amiodarone or something like that, we may be able to pin that as a cause for this change in their tissue, which we will describe as usual interstitial pneumonia. If we cannot find a particular cause for this histologic change in their lungs' interstitial tissues, then we will refer to that as idiopathic pulmonary fibrosis. Let's have a look at the pathophysiologic processes associated with this histologic pattern called usual interstitial pneumonia. So one of the more distinctive features, if you can look over to the left-hand side of my pointer, here we have the visceral pleura. It is tightly adhered, constituted by a layer of squamous epithelium and connective tissue that acts as this protective layer to the external lung. And what we're seeing is this deposition of fibrous material deep to the visceral pleura. And this fibrous material is largely collagen in nature, and it does not have a compliant stretchy property to. Hence, the lungs become restrictive, non-stretchy, or non-compliant, and that reduces the overall container size of the lung itself. If you look to the far right, you can see the pathophysiologic mechanisms laid out in a graphic. First, we have environmental factors, and this is going to be things in the case of idiopathic pulmonary fibrosis, things like smoking, occupational exposures, and viral infections that will come to bear on the pulmonary epithelium. If we have a patient that has at-risk epithelium because of advanced age, and we're talking about the age closer you get to 70, the more likely you are to develop IPF, and then some kind of genetic predisposition. They are still working out the details on the genetic predisposition, but they think that they have a couple of leads in terms of telomerase mutations or surfactant mutations, even variations in the genes that code for proteins associated with mucus. Having said all of that, the at-risk epithelium incurs an insult from these environmental factors, and that produces persistent epithelial injury. This gives rise to an inflammatory response, which induces cells like neutrophils to release pro-fibrogenic factors. This is going to be stuff like interleukins and those types of pro-fibrogenic factors that are going to cause, instead of the pulmonary parenchyma in its usual form, a fibrogenic, and that's a fibrous collagenous type of tissue, to be laid down. This, of course, is the fibrosis that we were talking about, and that fibrosis is going to cause the lungs to become stiff, non-stretchy, and non-compliant. Again, on the far right-hand side, we can see a deposition of these fibrous layers here. Instead of these organized cells with the organized and well-defined nucleus, here we can see scattered nuclei, and we can see deposition of fibers. Here you can see a clearing out of the space in the pulmonary parenchyma that should not be there, and that is a clearing out and giving rise to this kind of empty cystic structure. And if you get a number of those, it creates what we call a honeycomb lung pattern, which will be the terminal histological appearance of many folks with end-stage pulmonary fibrosis. So let's summarize where we've come so far with the graphic on the left. We're starting off with a restrictive lung disease pattern, and spirometrically that is going to refer to folks with pulmonary function tests that exhibit a normal FEV1 to FVC ratio, but a reduced forced vital capacity as a result of the shrinkage of the pneumatic container, so to speak. So we have excluded structural causes like chest wall abnormalities, and so we're thinking that it's going to be something to do with the interstitium. This is going to be a chronic disease in nature, and then if we can pinch off some of the patient's tissue from the lung and send it to pathology, they will identify that histologic pattern that we just reviewed that is usual interstitial pneumonia. If there is no cause, they don't have coal miner's lung or anything of that sort that we can blame it on, then we're going to say this is probably idiopathic pulmonary fibrosis. This refers to the clinicopathologic syndrome marked by progressive interstitial fibrosis and eventually respiratory failure. On the left-hand side, we see a graphic that nicely summarizes kind of the pathophysiologic features of IPF. Here we can see again in the right lower hand quadrant of the photograph, again, this deposition of fibrous material into the pulmonary interstitium, which is going to ultimately give rise to what we can see over here. Here we can see that the lung in this gross specimen has lost its compliant or stretchy component and instead is stiff and has started to clear out with a loss of tissue in the form of these bullae here. Now this lung, if we were to pick it up with our hand, would be stiff, kind of like when you have a sponge and you let it set all night and the water evaporates and it becomes hard and stiff. And that's kind of how lungs start to act when they have undergone this pathophysiologic process. If we take a chest x-ray of these folks, we're going to see these reticular lines that are going to predominate down in the bases of the lungs. And again, if we do a high-resolution CT scan, which will be part of their workup, we can see these areas of honeycombing, particularly in the bases, which represent an advanced change in the interstitial fibrotic changes of the bases of their lungs. So a word on IPF epidemiology. It is the most common of the idiopathic interstitial pneumonias, or that histologic pattern. We can see that it seems to be more common in folks of European and North American extraction than those of Asia and South America. And if we look at the prevalence from 2001 to 2011, it is increasing in prevalence. Now, if we go all the way down to the second to last column on the right, we can see that it produces more than 16,000 deaths annually in the United States, and that's more than bladder cancer, multiple myeloma, and acute myelogenous leukemia. And so it does represent, IPF does represent a significant burden of morbidity and mortality in the United States. Now, we have said that idiopathic, as the name suggests, idiopathic pulmonary fibrosis does not have a overwhelming environmental exposure that we can blame it on, such as coal miner's lung. But there are risk factors for it, which include environmental exposure. For example, if a patient is a cigarette smoker or has some degree of exposure to organic and inorganic aerosolized or particularized matter in their environment, then these things may enhance their capacity to get idiopathic pulmonary fibrosis. This last point under environment is many cases previously labeled as IPF may be actually a pneumoconiosis. And this kind of comes to the point that at this point in the evaluation of the patient, they should really be under the care of a pulmonologist, because these distinctions become very fine, very nuanced, and they require the care of a specialist. Also, you can see exposure to any number of viruses can increase the risk, as well as chronic aspiration and reflux. Now, keep in mind how common reflux is. I think we get a sense that if you have a patient with reflux, that may increase the risk of chronic aspiration. And so whether or not it is a cause or a side effect of IPF is one thing that the pulmonologist will have to sort out, but it does tend to be a very common comorbidity. In fact, some 80% of folks on lung transplant waiting lists for IPF have the diagnosis of reflux. Unfortunately, there's also a familial component with genetic causes being identified in up to 30%. Again, this is just another indication of why it's important for a specialist to be involved in these patients' care. Now, we have already touched on the pathophysiology. We know that the environmental factors, smoking, occupational exposures, viral infections, in the presence of folks that are closer to 75 in age tend to have a greater likelihood to contract IPF, and then folks that may have genetic mutations that give rise to this at-risk epithelium. This produces an injury. The injury produces an immune reaction, which is the neutrophils and other lymphocytes expressing these pro-fibrinogenic factors like interleukin, and this causes, instead of a normal cell signal, an abnormal intracellular signaling, which produces a proliferation of hard fibrotic collagen-based connective tissue instead of the usual stretchy and compliant pulmonary parenchyma. So how do folks with IPF IPF present clinically? Well, their initial symptoms on the left-hand side, you can see it's going to be something like a cough, which is usually non-productive, unless, of course, they're coming off the tail end of an acute bout of bronchitis. They typically do express complaints about shortness of breath, both with exertion and eventually at rest. And this can begin kind of insidiously. It seems like not that big a deal at first, but then progresses over time. Now, on physical exam, these folks are going to have almost universally fine crackles, end expiratory rales, or fine crackles in the bases that kind of have that Velcro-like quality in terms of sound. Digital clubbing can be present in over 25% of the patients, and so anybody with digital clubbing that has not been evaluated for that symptom should be investigated for other causes of digital clubbing in addition to IPF. And then we are not going to see extrapulmonary systemic involvement like we will in sarcoidosis. Sarcoidosis can show up in your eyes, your skin, your joints, your heart, your lungs, but IPF restricts itself to the lungs. But it would behoove you to evaluate the patient for those comorbidities, things like GERD and obstructive sleep apnea and things of that sort that might be associated with IPF. When we talk about doing a history and physical examination on a patient with this presentation, we're talking about a very detailed history that's going to go deep into social history in terms of occupation and potential exposures. And a history that you might see would be something like on the right, a 55-year-old female current smoker with a 9-month history of respiratory symptoms, including dyspnea on exertion, occasional thoracic pain, and then dry cough. We listen to him, hear some inspiratory crackles, we get a chest x-ray in the office and order some pulmonary function tests, and that, of course, is going to show a restrictive pattern in the form of normal to increased FEV1 to FVC ratio, but decreased lung volumes. Now, having said that, we will eventually proceed to a workup that includes to a chest x-ray, and you can see that on the right. Here we have these reticular lines which represent that fibrotic changes in the interstitium, and these are going to start at the bases or progress cephalota more towards the head as the patient's course advances. On the right-hand side, you can see additional chest x-ray, but also this kind of typical pattern that we see over here. This is that honeycombing where those structures have been cleared out as a result of fibrotic changes. Again, we see these in the bases, and then they tend to progress more toward the head depending on the severity of the disease. Now, the other things on the left-hand side, we've also have some laboratory studies, and these things are going to be like erythrocyte sedimentation rate, which is going to be elevated in a good chunk of these people as a result of the presence of inflammation, which is exactly what's going on in terms of the epithelial and immune response. However, a lot of these things are going to be done to evaluate for possible causes. And so what one might do as a generalist in primary care is just get the PFTs, the chest x-ray, some basic lab work, and then defer the more specialized stuff for the pulmonologist and the rheumatologist, which no doubt the patient will eventually see sooner rather than later in terms of referrals. Echocardiography is a good idea in patients in whom you suspect secondary pulmonary hypertension. As the lungs become more non-compliant or more non-stretchy, the pressures associated with the pulmonic circuit will increase and eventually can wear out the right ventricle, causing right ventricular failure associated with lung disease, which we would refer to as cor pulmonale. So from a generalist standpoint, the management of idiopathic pulmonary fibrosis is pretty straightforward. Refer to pulmonology. Now, a pulmonologist is going to have to ask themselves, what can we do to help this patient? Well, in terms of pharmacologic therapy, there are things that they may want to avoid giving the patient so that it doesn't make the fibrosis worse. But to tell you the truth, outside of like anti-reflux therapy, which you should give to all patients with IPF and any kind of evidence of reflux, there's not that much to do in terms of things, pharmacologic therapies. For example, this Esbriet has not been shown to be especially effective, and it costs something like $11,000 a month. And so mostly these treatments are going to rely on oxygenation, rehab, and then if the patient is smoking, they need to stop smoking. If the patient becomes acutely ill, they can become ventilated, but that is going to be a very difficult situation. And these patients can undergo lung transplantation if they're healthy enough. Keep in mind that ongoing smoking is an absolute contraindication to lung transplantation. So if you have a patient who is otherwise a candidate, they cannot be an active smoker and receive a new set of lungs. All of this is going to be rolled up into the province of the pulmonologist care, and what we're going to be doing is help coordinating care and making sure that we look at their recommended treatment plan and follow that so that we can assist in the patient's management. An important component in the evaluation of IPF is going to be prognosis. Now, of course, we are going to defer any determinations about prognosis in a disease state like this to the specialist, but it's important for us to know in terms of our overall patient management. Here's a quote from Up to Date. The median survival of IPF has been reported to range from 2 to 5 years. This estimate reflects the range of average life expectancies observed in cohorts of IPF patients rather than the limits of an individual patient's life expectancy. This nuance is important as the actual range of survival of individual IPF patients is quite broad, with up to 20 to 25% of patients living beyond 10 years. So, defer prognosis to the pulmonologist, but be aware that some patients may have a fairly dismal prognosis and it may be highly variable. In terms of the range of interstitial lung disease, we have already covered coal miner's lung as a pneumoconiosis, which is a form of lung disease, interstitial lung disease, that is attributable to these occupational exposures. Now, coal mining is becoming less and less common, but there are other occupational exposures that are still common, still widely practiced, like the gentleman on the far hand right, who is going to be exposed to silica dust. And so it is important to keep in mind that anytime a patient has this kind of restrictive lung disease, chronic shortness of breath, non-productive cough, to dive deep into the history and make sure that you round up any occupational or environmental exposures. Also keep in mind, as we continue brief coverage of usual interstitial pneumonias with a cause, folks with connective tissue diseases such as rheumatoid arthritis, that can be the cause of their interstitial lung disease, and that will prompt a referral not only to pulmonology but also to rheumatology if they haven't already been diagnosed and treated by a rheumatologist. Lastly, before we move on to granulomatous lung disease, is toxicity. This is a form of interstitial lung disease, the histologic pattern of usual interstitial pneumonias that is caused by a toxic exposure to a medicine. And by that I mean we haven't given the patient too much. The patient has just responded in this way to the medication. This can happen in folks taking nitrofurantoin, that's brand name is going to be Macrobid, which some patients may take for suppressive therapy and chronic urinary tract infections. And then things like amiodarone, which patients take for a number of reasons, usually cardiac patients. It's important to keep these things in mind because if you have a patient that's going to be taking amiodarone chronically, they need to have pulmonary function tests as well as thyroid studies every year to evaluate for the toxic effects of that medication. So if you have patients on these medications, make sure that you keep out for any monitoring guidelines that would help detect the toxic effects of any of these medications that you may have prescribed for your patient. So next up in our treatment of chronic interstitial lung disease, also called diffuse parenchymal lung disease, is going to be granulomatous disease. Now, we've already talked about how hypersensitivity pneumonitis can be grouped into pulmonary fibrosis as well, depending on how the histologic changes turn out. We also have treated hypersensitivity pneumonitis in our occupational lung disease video, so now we're just going to talk about sarcoidosis. This is a fascinating illness. Sarcoid comes from the Greek sarkos, which just means flesh, and so a sarcoma would be a tumor that is composed of flesh. Sarcoidosis is a systemic disease which produces a number of interesting histologic changes, but the long and short of it is going to be non-caseating granulomatous disease. We're going to talk about the salient characteristics of this disease, but the main thing you can see on the far right-hand side is sarcoid granuloma of non-caseating nature, and you can see these giant cells that have infiltrated the center and the so-called Schaumann bodies. This histologic change is the basis for this disease, and it occurs not only in the lungs, but in the eyes, the heart, the skin. As we'll soon see, it is a multi-system, multi-organ disease. Now, the types of this, you can get acute sarcoidosis, which resolves over a period of a couple of years. I have a friend that was a professor, and he was diagnosed with this. He spent about a year and a half not working, and then after resolution of symptoms, he returned without virtually any deficit. Versus chronic sarcoidosis, a disease that persists for more to 3 to 5 years, and then refractory sarcoidosis, those folks that have really bad persistent, progressive, and unremitting granulomatous changes that affect multiple tissues and sites, and despite full therapy, they just don't tend to get any better. We talked about how this is a multi-system disease. The lungs, the intrathoracic lymph nodes, skin, spleen, heart, liver. A lot of places can be infiltrated by these granulomas. These can form into nodules and mass lesions, and this consolidation effect is exactly the type of thing that diffuses all of these non-stretchy granulomatous stiff tissues into the lungs, producing this restrictive lung disease. And this slide just kind of drives home the nature of sarcoidosis. You can see in uveitis up here, infiltration into the liver. Here, this granulomatous disease is infiltrating into the heart, which can cause heart block and arrhythmias by inhibiting conductive tissue and things of that nature. These sarcoid granulomatous changes, again on the right-hand side, you can see that they can infiltrate into the bone, soft tissue, and skin of the patient. And so here is the disease process on the right. We can see that this non-caseating granuloma in the form of sarcoidosis, which is actually stimulated by an immune process, versus the caseating, which has central necrosis, caseating granulomas, which may be associated with tuberculosis or other infections. So in terms of epidemiology, sarcoidosis tends to be more common in black person as compared to whites, a wide range of prevalence from 4.7 to 64 per 100,000 persons. 70% of cases reported in the United States occur in patients 25 to 45 years of age, and so that it tends to be a young to middle-age-ish type of illness. As with the other interstitial lung diseases, there does tend to be a possibility for genetic predisposition. We don't need to know the details of that, but also there tends to be a possible environmental exposure. In terms of pathogenesis, we're going to hear a familiar story of a possible genetic predisposition and then possible environmental exposures in the form of infectious agents, organic particles, or inorganic particles. These exposures will trigger an immune reaction, and the terminal pathway of the immune reaction is going to be the release of factors which will initiate granulomatous changes. Some patients may experience resolution, but some patients may go on to have pulmonary fibrosis and then chronic forms of sarcoidosis. When patients present with sarcoidosis, about a third are going to be asymptomatic. Well, how does that happen? Well, they may come in with a cough and cold, concern for pneumonia. We get a chest x-ray and then discover that they have bilateral hilar adenopathy. They may more commonly come in with cough of unknown cause, a non-productive cough, shortness of breath, pleuritic chest pain, which is worse when you take in a deep breath, wheezing or bronchial hyperactivity. It is also common to see systemic changes in the form of fever, weight loss, and fatigue. And then, of course, if they have multi-organ manifestations of the disease, you may see some abnormalities on an ocular exam or a derm exam. And of course, it's important to look at the range of possible sites when performing a history and physical examination. When evaluating a patient for possible sarcoidosis, it will not be clear exactly what you're dealing with initially, and so you may order some laboratory studies to evaluate for other causes, for example, connective tissue disease, and things of that sort. But one recurrent theme is going to be elevated ACE levels, which tend to be elevated in up to 80% of folks that have sarcoidosis. That has to do with the elevated ACE levels that occurs as a result of the widespread and high volume granulomatous changes, one of the byproducts of which is angiotensin conversion enzyme. Interestingly, this has no impact on their blood pressure or anything of that sort, but it can be used to help evaluate in terms of possible sarcoidosis. We have already talked about how sarcoidosis will produce a restrictive lung disease, which is going to be an FEV1 to FVC ratio, which is normal or high, but then a low vital capacity. If you do a diffuse lung capacity test, you'll see that it's reduced in terms of interstitial lung disease, and that will be pretty well applicable to most folks that have sarcoidosis, but occasionally they can have mixed and obstructive defects are possible. When you refer patients for evaluation at pulmonology, they may do a bronchoscopy and biopsy particular lesions, but if a patient has extra pulmonary manifestations like erythema nodosum on the right, they could also just have a dermatologist biopsy those lesions, and if it shows granulomatous disease, it can be established on the basis of that peripheral lesion rather than being forced to take a lymph node or some other more invasive form of biopsy. So here we have the classic radiologic manifestation of sarcoidosis, bilateral bulky hilar lymphadenopathy. And so anytime you see this clinically or on a board exam, you definitely want to consider sarcoidosis as the cause. Here's a couple of more radiographs that show the advancement of the bilateral hilar adenopathy. And then we can see on the right-hand side the CT scan of a patient with sarcoidosis that's rather advanced, and we can see these kind of hairy-looking little spherical objects. Those are ground glass pulmonary nodules and then diffuse reticulonodular changes. In the graphic on the right, you see a more rare variant of sarcoidosis called Herfort's syndrome. And this is where the granulomatous disease changes infiltrate the head and neck, producing uveitis and parotid lacrimal and submandibular gland involvement. And these can be evaluated with a radionuclide scan where that radioisotope goes anywhere where there's increased inflammation. And you can see this fellow on the right, he's got this large parotid gland involvement, and you can see that that's going to cause a Bell palsy because of the infiltration right next to the seventh cranial nerve. So if you suspect that you have a patient with sarcoidosis, you need to refer them to pulmonology. And so these patients, if they have that gentle remitting type of disease, may get better within a couple of years, but it's going to be important for you as a primary care practitioner to do some things on an every 6 to 12 month basis, depending on what your pulmonologist and or rheumatologist suggest. But things like an EKG, eye exam, pulmonary function test, renal function, and then calcium levels. And this is going to give us an indication of if the disease is spreading to other organ systems, and then in terms of calcium level, whether or not there is a great burden of granulomatous disease at one point compared to another. So for the pulmonologist, the treatments are going to involve things like nonsteroidal anti-inflammatories, corticosteroids, and things of that sort. And of course, these were the province of the specialists, so we don't need to spend a lot of time on this. But in terms of prognosis, again, we will defer this to the pulmonologist, but it's going to be favorable in certain forms rather than others. So for example, Lofgren syndrome, those folks tend to have a more mild form of the disease. And then some folks tend to have a more aggressive form of the disease, in which case, if they do have advanced disease with a vital capacity of less than 50%, then they may be eligible for a lung transplant. Follow-up should be continued for 3 years after post-treatment. So if somebody is showing significant improvement, then you follow them for 3 years to make sure that they don't have a recurrence. But again, that will be under the supervision of a pulmonologist. This marks the end of the video on interstitial lung disease.